Right now, I mean, the UK economy is losing something like $2.4 billion a year.
Which is just a massive number.
Right. And roughly 333,000 highly experienced women are just walking away from their careers. But this mass exodus isn't due to some sudden recession.
No, not at all.
It has absolutely nothing to do with corporate culture shifting. It is driven by a completely natural biological transition that affects, a full third of the female population.
And yet it's still treated in the workplace.
And in the doctor's office.
Exactly, like this bizarre medical mystery. It's a staggering blind spot. We were talking about 13 million women currently navigating this in the UK alone.
Yeah.
And when you look at the systemic impact, it touches literally everything, from corporate leadership pipelines to global healthcare equity.
Welcome to the deep dive. For you listening, we have a very specific mission today. We're opening up our stack of sources, which includes the official clinical guidelines from nYou and the British Menopause Society.
Plus the NHS reference texts.
Right, and this incredibly comprehensive 2025 demographic data from Chemist4U. And we are setting out to answer what seems like a totally simple question. What is the average age for a woman to reach menopause in the UK?
But getting to that one number,
Yeah.
it unlocks a much larger conversation.
Oh, massively. We're unpacking not just the biological timelines, but the actual mechanisms of what's happening in the body.
And why this totally alters long-term health and how it's basically reshaping the economy. Because our goal here is to decode the data. We're looking at the biological hardwiring, the socioeconomic variables, and the medical shifts.
Yeah.
Shifts that are finally addressing this not as some brief phase of discomfort, but as a really critical window for health.
Okay, let's unpack this mission question right away. But the clinical data gives us a very clear baseline. The average age of menopause in the UK is 51.
But, that number sits within a recognized normal range.
Yeah.
Usually it's spanning from 45 to 55 years old.
Right.
And the word average is doing a lot of heavy lifting there. Clinically, menopause is just defined as a single point in time. It's exactly 12 consecutive months without a menstrual cycle.
But biology rarely operates on a switch. Because 51 is basically just the final destination.
Yeah, arriving at the end.
The actual physiological process, perimenopause, is the multi-year road trip to get there. The data shows early perimenopause typically starts around age 47.
And late perimenopause at 49.
Right. And this is not some smooth linear decline. It's an unpredictable roller coaster that can last anywhere from 4 to 10 years.
To understand why it's so unpredictable, you really have to look at the communication between the brain and the ovaries.
Yeah.
During perimenopause, the ovarian reserve, so the remaining eggs, is depleting. The brain is trying to stimulate the ovaries by sending out follicle-stimulating hormone.
FSH.
Right, FSH. But because the ovaries are running out of follicles, their response is super erratic. Like 1 month they might overrespond to produce a surge of estrogen, and the next month they barely respond at all.
Which brings up a fascinating and frankly kind of counterintuitive shift in how this is diagnosed.
Oh, definitely.
According to the British Menopause Society and nYou guidelines, if a woman is over 45, menopause is diagnosed entirely by her symptoms.
Things like hot flushes, mood changes.
Irregular cycles, yeah. And her clinical history. The guidelines explicitly state that no blood tests are required.
They actually actively discourage routine blood testing for this age group.
Unless there's severe clinical uncertainty. But I have to ask, why no blood tests? Isn't modern medicine all about hard data?
I know, it sounds totally backward to reject lab data, but those wild hormone fluctuations we just talked about, they make a single blood test practically useless.
Oh, because it changes day to day.
Exactly. Drawing blood to check estrogen or FSH during perimenopause is like trying to judge the weather for an entire year based on one photograph taken on a Tuesday in April.
Wow, okay.
The snapshot might show a sunny day, but it tells you absolutely nothing about the hurricane that hit the week before.
I see the logic, but I have to push back on the reality of that in a clinic. We're so conditioned to want hard data. If a patient feels terrible, a test feels like validation, right?
Oh, absolutely.
By removing the test, aren't we just leaving women at the mercy of whether a doctor, believes their symptoms are severe enough?
That is the exact tension in the medical community right now. But the intention behind the guidelines is actually to prevent doctors from dismissing patients based on a normal lab result.
Ah, I see.
Historically, a woman would report debilitating symptoms. The doctor would pull blood on a day her estrogen happened to be surging, and they'd say, well, your levels are fine. It's not menopause.
That sounds incredibly frustrating.
It was. So by removing the test requirement, the guidelines are officially empowering the clinical value of the patient's lived experience.
So the symptom is the data.
Precisely. The subjective experience is a much more accurate reflection than a volatile blood draw.
But the playbook completely flips when we look at the exceptions to this timeline, right?
It does.
Our sources highlight two distinct categories where this accelerates. First, there's early menopause, which is between 40 and 44. That affects about 5 in 100 women.
And then there's POI.
Right. Premature ovarian insufficiency, where menopause happens before age 40. That affects 1 in 100 women. And incredibly, 0.1% of women experience it under the age of 30.
What's fascinating here is how the diagnostic protocol changes for this specific group. For women under 40 or under 45 with atypical symptoms, doctors do not rely solely on the interview.
This is where they want the hard data.
Exactly.
Hmm.
Blood tests become the crucial diagnostic tool. They're looking for that FSH to be elevated. Specifically, greater than 25 international units per liter, measured on 2 separate occasions.
Alongside at least 4 months of irregular or absent periods.
Right. And if the FSH levels are inconclusive, the guidelines mention checking AMH.
Anti-Müllerian hormone.
Yes. Think of AMH as a chemical roll call for the remaining ovarian reserve.
Oh.
While FSH is the brain shouting at the ovaries to work, AMH is the remaining follicles whispering back. So a very low AMH level is a highly specific indicator that the physical reserve of eggs is nearly gone.
So when we talk about a woman in her 20s or 30s facing complete ovarian insufficiency, what actually triggers that biological shutdown so early?
Synthesizing the data, we really see 2 major pathways. The first is heavy biological hardwiring. Genetics account for roughly 50% of the variation in timing.
Wow, 50%.
Yeah. Researchers have identified nearly 300 different genetic signals associated with ovarian aging. It's a highly complex polygenic trait. If a woman's mother or sister experienced early menopause, her own risk profile is significantly elevated.
But it's not entirely DNA, right? The nYou data highlights some severe environmental triggers.
Absolutely.
The one that really stands out is that smoking literally doubles the risk of experiencing premature menopause.
The severe compound effect. The toxins in cigarette smoke, particularly these polycyclic aromatic hydrocarbons, are endocrine disruptors.
So they mess with the hormones.
Worse than that, they actually induce apoptosis, which is programmed cell death, right in the ovarian follicles. The smoke accelerates the physical destruction of the eggs.
That's terrifying. But smoking is an individual behavior. The data also reveals massive timeline shifts based on factors women have absolutely zero control over.
Yeah, this is crucial.
Here's where it gets really interesting. That average age of 51 is heavily skewed by demographics. South Asian women in the UK experience menopause drastically earlier than white British women.
The numbers are stark.
We're looking at an average of 46.7 years for Indian women and 47.1 years for Pakistani women. That is almost a half-decade earlier than the white British average of 51.
And when we pan out to the global Chemist4U data, we find this 0.47 correlation between a country's average level of personal wealth and the age of menopause.
Wait, a 0.47 correlation? That is surprisingly strong for global demographic data. Are we really saying a woman's biological clock is literally ticking to the rhythm of her country's GDP?
In a lot of ways, yes. That correlation points to the compounding burden of environmental and physiological stress.
How so?
While wealthier nations generally offer better lifelong nutrition, lower rates of childhood infectious diseases, and reduced exposure to environmental toxins, all of that preserves the ovarian reserve.
And the reverse.
Conversely, chronic physiological stress from a lower socioeconomic environment creates a higher allostatic load on the body, which just accelerates reproductive aging.
Which brings us to a very uncomfortable reality regarding healthcare equity right here in the UK.
Right.
The sources clearly outline that women from lower socioeconomic backgrounds, which heavily overlaps with the UK's Black, Asian, and minority ethnic populations, are 30% less likely to be prescribed hormone replacement therapy.
If we connect this to the bigger picture, we uncover this huge compounding health disparity. You have a demographic of South Asian women biologically predisposed to hit menopause up to 4 years earlier.
Meaning more of their life is spent in an estrogen-depleted state.
Exactly.
Yeah.
Yet, they are significantly less likely to receive the primary medical treatment designed to protect their long-term health from that exact depletion.
It's failing them on both ends. And if women are experiencing this earlier and systemically missing out on treatment, the fallout in their daily lives must be immense.
It is.
Let's look at the actual reality for those 13 million women. Between 80 and 90% will experience perimenopausal symptoms. And for 25% of them, those symptoms are classified as severe and debilitating.
We're talking severe joint pain, profound brain fog, night sweats.
And hot flushes that last an average of 7 years, sometimes over a decade.
It's vital to understand the mechanism behind those symptoms because they aren't just mild discomforts. Take the hot flush.
Okay.
Estrogen plays a major role in the brain's hypothalamus, which regulates body temperature. When estrogen levels become erratic, the hypothalamus gets confused. It suddenly misreads the body's normal temperature as dangerously hot. So the brain triggers an emergency cardiovascular response. Rapid heart rate, massive vasodilation of blood vessels, intense sweating, all to cool down a body that isn't actually overheating.
That sounds physically exhausting.
It really is.
And then you place that physiological emergency into a professional environment. 8 in 10 menopausal women are currently in the workforce.
Right.
The workplace shockwave we mentioned earlier is entirely driven by a lack of systemic accommodation for this biology. The data shows 10% of women eventually leave their jobs entirely due to the severity of their symptoms.
And to put the hard economics on that from the FP Analytics report, the UK loses 14 million workdays a year specifically to menopause symptom management,
14 million.
which translates directly to a $2.4 billion loss in income.
It's functioning like a localized recession. Workplaces have just optimized for a baseline that completely ignores the reality of a third of the female population. I mean, how many senior leaders, how many directors are we losing at the peak of their careers simply because corporate culture doesn't know how to talk about chronic night sweats or brain fog?
It's an incredible drain on institutional knowledge.
Yeah.
But the career impact is really just the short-term consequence.
Right, because of the long-term health risks.
Exactly. If women are forced out of the workforce due to severe symptoms, the clinical question is, why aren't more of them accessing the medical treatment that alleviates those exact symptoms? And how is that lack of treatment affecting their physical health over the next 3 decades?
Because estrogen is not just a reproductive hormone, it's a structural protector for the entire body.
That is the most critical takeaway from the clinical guidelines. Estrogen maintains the elasticity of blood vessels, preventing plaque buildup in the heart.
Wow.
It regulates cellular balance in our bones, ensuring we build as much bone as we break down. It also promotes neuroplasticity in the brain.
So when estrogen drops rapidly,
The risk profile for osteoporosis, severe cardiovascular disease, and cognitive decline just spikes dramatically.
this explains the urgency in the guidelines for women with premature ovarian insufficiency or early menopause. Women under 45 are highly encouraged to take hormone replacement therapy until at least the average age of 51.
Yes, their skeletal and cardiovascular systems are biologically expecting another decade of estrogen protection. Without HRT, their bodies basically age at an accelerated rate.
The clinical consensus is absolute on that front, right? For early menopause, HRT isn't just about symptom relief.
No, it's a vital protective medical intervention to prevent premature morbidity.
Looking at the general population, though, we are seeing a massive rebound in treatment access. Currently, about 14% of UK women take HRT, but the numbers are surging.
They really are.
The NHS reported a 22% increase in prescriptions just in the 2023-24 period. Part of that is driven by a recent UK government scheme that capped HRT prescription costs at under £20 a year.
Which removed a huge financial barrier. Accessibility is improving, but there's still this massive psychological barrier for many patients, and honestly, even some GPs.
I want to challenge this rebound on behalf of the listener, actually.
Sure.
I'm looking at this 22% increase, and I'm remembering the massive global panic in the early 2000s. Front page headlines linking HRT to breast cancer and heart attacks.
The WHI study.
Right. So how much of this current surge is driven by a genuine, data-backed correction in the science versus just a cultural shift where women are finally demanding relief regardless of the risks?
It is entirely driven by a correction in the scientific analysis. The panic you're referencing stems from the 2002 Women's Health Initiative study.
Okay.
The problem was not the data itself, but the methodology and how it was applied. The researchers were studying women who were, on average, 63 years old.
Oh, so well past the average age of 51.
Exactly. Many of them were starting HRT a decade or more after they had already gone through menopause,
Yeah.
after their arteries had already stiffened and their biological baseline had completely changed.
So they took the adverse reactions of women in their mid-60s and applied that risk profile to women in their late 40s who were just starting perimenopause.
That's exactly what happened. When the clinical community finally reanalyzed the data, stratified by age, the risk profile completely inverted for the younger cohort.
Wow.
This established what the British Menopause Society now calls the window of opportunity. If a woman starts HRT before the age of 60, or within 10 years of the onset of menopause, the treatment actually reduces the risk of coronary heart disease.
It reduces it.
Yes, and lowers all-cause mortality. The risks of breast cancer, particularly with modern body-identical transdermal hormones, are statistically lower than the risk increase associated with drinking 2 glasses of wine a day or being clinically obese.
That is a staggering reframing of the risk.
The protective benefits for the heart and bones in that window are just profound.
So we started with the mission to find a single number, 51. But that number is clearly just a doorway into an incredibly complex biological and societal landscape.
It really is.
The timeline of reproductive aging is dictated by this massive web of 300 genetic signals compounded by environmental toxins and heavily influenced by the economic wealth of a given demographic.
I'd actually like to leave the listener with one final thought to mull over. Looking at the chemist for you demographic data from a totally different evolutionary angle.
Okay.
Because of modern advances in life expectancy, women in developed countries now live approximately 30 years after menopause.
30 years. That completely upends the traditional medical view. We've historically treated menopause as a deficiency of youth, right? A biological winding down.
Rather than its own distinct biologically intended life stage, it demands a complete reframing of the narrative. 30 years is over a third of a total human lifespan, lived entirely post-menopause.
Wow.
From an evolutionary standpoint, human biology did not preserve a 30-year post-reproductive chapter by accident.
It's not an error.
No, this isn't an end. It is an entirely distinct extended phase of human life, a phase of sustained cognitive contribution, leadership, and societal value. And medicine and corporate infrastructure are only just beginning to properly support and optimize it.
When we started this deep dive, we highlighted the lack of a clear diagnostic test for this transition. There's no simple X-ray to show you exactly where you are on the timeline.
Right.
But perhaps the goal shouldn't be to force this massive biological shift into a neat binary box. The goal is to build better systemic infrastructure, better corporate policies that retain 300,000 brilliant minds.
Unbiased healthcare protocols.
Exactly. Protocols that don't leave systemic gaps based on your ethnicity. And a deeper scientific understanding of long-term preventative care. Because when a third of the population goes through a transition this profound, you shouldn't have to navigate it alone. Thanks for joining us on the Deep Dive.